Hey everyone, welcome to The Explainer. Look, if you're a young doctor just stepping into the ICU or managing critically ill patients on the wards, you already know that mechanical ventilation can feel, well, pretty intimidating. But today, our mission is to cut right through that noise. We're going to equip you with a reliable, evidence-based framework for interpreting arterial blood gases in ventilated patients so you can confidently optimize your settings and ultimately improve your patients' outcomes.
Okay, let's dive right into this absolutely crucial question. Think about it. When a patient is in severe respiratory distress, their body is constantly fighting to maintain balance, right? They're breathing faster to clear acid, taking deeper breaths for oxygen. But the very second you push those paralytics and sedatives and secure that endotracheal tube, boom, their natural compensatory mechanisms are completely shut down. Those mechanisms immediately become your responsibility at the bedside. You are now quite literally the patient's brainstem.
To get you comfortable with that power, we're following a clear, clinical mastery arc today. 1. The ventilator toolkit. 2. Systematic ABG interpretation. 3. Tackling hypoxemia. 4. Correcting acid-base imbalances. And 5. Special clinical scenarios.
Starting with Section 1, the ventilator toolkit. Let's look at the primary levers of power you actually control on the mechanical ventilator. Think of this as your absolute must-know cheat sheet. Notice how we divide your dials into two totally distinct camps. On one side, you've got your ventilation controls. Tidal volume, which is the actual size of the breath, and respiratory rate, the frequency of those breaths. Together, these control carbon dioxide clearance. On the flip side, you have your oxygenation controls. FiO₂, the percentage of oxygen you're delivering, and PEEP, the pressure keeping the alveoli stented open at the very end of a breath.
So, the really crucial point here is minute ventilation. It's just the product of respiratory rate multiplied by tidal volume. Minute ventilation dictates exactly how much CO2 you blow off. If your patient's ABG shows they're retaining CO2, you've got to increase that minute ventilation. If they're blowing off way too much, you decrease it. It really is that foundational.
Moving right along to Section 2, Systematic ABG Interpretation. Because knowing your tools is only half the battle, now we need a diagnostic framework.
You definitely don't want to freeze up when a nurse hands you a freshly printed complex ABG slip at 3 a.m., right? Notice how this 5-step approach simplifies interpretation into highly logical steps. You don't just stare at the pH and guess. First, check for hypoxemia using PaO₂. Then, review the pH to see if we're acidic or alkaline. Next, look at the PaSO₂ for the respiratory component, followed by the bicarb for the metabolic status. And finally, combine them to find the primary cause.
And you know, this foundational approach naturally builds right into the comprehensive 7-step mental checklist used in advanced critical care. By explicitly separating the origin of the imbalance in Step 5 and checking for exact compensation in Step 6, you can confidently process any blood gas on the wards. You'll know instantly if the kidneys have started retaining bicarbonate to compensate for a chronic respiratory issue, or if you're dealing with an acute, totally uncompensated emergency.
Okay, Section 3, Tackling Hypoxemia. With our diagnostic framework locked in, let's look at how to safely tackle a low PaO₂. If your patient is hypoxemic, your fastest fix is cranking up the fraction of inspired oxygen, the FiO₂. It's a quick fix for sure. But, as physicians, our golden rule is do no harm. Prolonged exposure to high concentrations of oxygen actually damages pulmonary tissue and promotes oxygen toxicity. So your goal is always to use the absolute lowest FiO₂ necessary to hit a safe target oxygenation. Then there's the other half of your oxygenation toolkit, PEEP. Optimizing PEEP is literally popping open collapsed alveoli and recruiting lung tissue, which effectively increases the surface area for gas exchange. But honestly, it's a double-edged sword. Excessive positive pressure can overdistend healthy alveoli, causing barotrauma, and that increased intrathoracic pressure can severely impair venous return, dropping your patient's cardiac output. It demands a very careful, individualized balance.
That brings us to Section 4, correcting acid-base imbalances. This is where your minute ventilation levers really come into play to manipulate blood pH.
Now, respiratory and metabolic acidosis, fundamentally different beasts. If the ABG shows respiratory acidosis, meaning high CO2 and low pH, you can fix that directly with the vent by increasing the respiratory rate or tidal volume. But if it's a metabolic acidosis driven by low bicarb, tweaking the vent isn't the cure. You have to treat the underlying systemic cause, like DKA or renal failure, while just temporarily using the ventilator to support their compensatory hyperventilation. Conversely, when you're staring down alkalosis, the whole strategy flips. For respiratory alkalosis, meaning oops, the patient is being overventilated, you absolutely must reduce minute ventilation to allow that CO2 to safely accumulate back to normal. If it's a metabolic alkalosis, maybe from diuretics or GI losses, you once again have to chase down the metabolic culprit, making sure you don't unnecessarily hyperventilate the patient and make the alkalemia worse.
Finally, Section 5, Special Clinical Scenarios. Because, as we all know, patients on the wards rarely read the textbooks, and standard rules require some finesse.
Take ARDS, for example. These lungs are incredibly stiff and severely inflamed. If we try to force a perfect, normal ABG by pushing huge tidal volumes, we will literally tear the lungs apart with high driving pressures. Instead, we use a strategy called permissive hypercapnia. We strictly stick to low tidal volumes, around 4 to 6 milliliters per kilo, and we simply tolerate the resulting high CO2 and lower pH. We're prioritizing lung protection over perfect numbers on a page.
Let's actually test this out with a real bedside case. Picture this. You've got an 80-kilogram patient. Their ABG shows a normal pH of 7.43, but a high CO2 of 53 and a high bicarb of 33. The current vent is set to a respiratory rate of 16, a tidal volume of 400, PEEP of 6, and FiO2 of 60. Oxygenation is fine with a PaO₂ of 127. So, what is your immediate move?
Okay, the absolutely critical takeaway here? Look at that elevated bicarb. This is a compensated respiratory acidosis. They are a chronic CO2 retainer. You must never rapidly blow off their CO2 or you'll cause a severe alkalosis. But you do still need to adjust the vent. That tidal volume of 400 is too low for an 80-kilo patient. It needs to be 480 to 560 to hit that 6 to 8 ml per kilo target. To maintain minute ventilation safely, you bump the respiratory rate to 20 or 22. And finally, that FiO2 of 60 is way too high for a PaO₂ of 127, so dial that down to 40% to prevent oxygen toxicity.
And that case really highlights exactly why understanding the underlying disease is so vital. In obstructive diseases like COPD and asthma, airway resistance is off the charts. If you breathe for them too fast, they can't exhale fully. Air gets trapped beat after beat, leading to dangerous dynamic hyperinflation, which we call auto-PEEP. To prevent this, we deliberately use lower respiratory rates and smaller tidal volumes just to maximize their expiratory time.
So, this summary table kind of brings the whole shebang together. It clearly shows that every single dial adjustment absolutely must be tailored to the specific pulmonary pathology you're fighting. ARDS requires strict, low tidal volumes. Obstructive diseases demand prolonged expiratory times. Restrictive lung diseases often need higher PEEP to overcome poor distensibility. There is simply no one-size-fits-all ventilator setting.
So I'll leave you with this final thought before you head back to the wards. When you look at that printout and reach for the ventilator dials, are you just treating the numbers printed on the slip to make yourself feel better, or are you truly optimizing the dynamic, living, complex patient right in front of you? Thanks for joining me for this explainer. Keep questioning, keep learning, and I'll catch you next time.